Welcome, everyone, to today's virtual forum, A Pathway Beyond the Crisis, What's Next in the Opioid Use Policy. We're so glad you could join us for this timely conversation. For the first thing we're going to do today is take a poll. Please take a moment to pull out your phones and participate in our opening question. Please register by texting Health Policy 261, no spaces, to 22333, or by visiting pollev.com/healthpolicy261. Our question today is, what are you most interested in hearing about from our speakers? And I'll give us a few seconds to join in and populate a few responses. I'm not seeing any responses coming in at this point. I think people are still joining the forum, and so I'll just give it a few more seconds. Okay, see us. One response is, in response to the question, what are you most interested in hearing about from our speakers today? One response is state actions using settlement dollars. The current state of policy discussions. And I think I'll move us along as those responses come in. I know that our speakers will definitely be able to touch on those two topics. So I'm going to move us ahead and dive into today's conversation. I'm Renee Gross, Senior Health Policy Consultant at Kaiser Permanente's Institute for Health Policy. At the Institute, we host events and publish information to shape policy and practice on important health topics. We convene experts to share knowledge, spark discourse, advance collective thinking, and explore opportunities to cultivate healthy communities and promote more accessible, high-quality care. As many of you know, overdoses remain a leading cause of death in the United States, and most involve opioids. In 2024, overdose deaths dropped below 80,000 people, the largest single decrease since the start of the opioid epidemic. Many factors play a role in this decline, from the increased availability of naloxone to improving access to evidence-based treatments, to the U.S. Department of Health and Human Services' comprehensive harm reduction approach. Today, we want to further examine the policies and programs that are working to reduce opioid deaths, along with focusing on the future state of the crisis. I'm pleased to kick off today's conversation with leaders who are working to shape public policy at the city, state, and federal levels in ways that will support and enhance recovery and care. First, I want to cover a few housekeeping notes. After the panel discussion, we'll take questions from the audience. You can submit questions through the Ask a Question box on your screen at any point during the forum. If you're on a large screen, it'll be to the right of the main window and on a smaller screen directly below. We likely won't have time to get to every question, but we'll do our best to answer as many as possible. If at any point you experience technical difficulties, please submit a question to the host through the Ask a Question box. This event is being recorded, and the video will be made available on the Institute for Health Policy's website within the next couple of weeks. So on to our content for today. It's my pleasure to introduce our moderator, Dr. Sara Leitz. Dr. Leitz is an addiction medicine physician in Portland, Oregon, with Northwest Permanente Medical Group. Her focus is on increasing awareness of the harms of substance use, along with reducing stigma and normalizing diagnosis and treatment of substance use disorders. She is the Kaiser Permanente National Clinical Lead for Harm Reduction and Addiction Medicine and the Medical Director for the Brookside Center for Residential Addiction Medicine. Welcome, Dr. Leitz, and our panelists.
Thank you very much, Renee. I am very excited to be here alongside you all to hear from our panel of experts. Before we get started with each of their opening statements and introductions, I'd like to take a moment and think about 3 patients who've got us to where we are today. In the work that I do every day, the patient's story and their lived experience drives changes and improvements, and I think that this is important for us to recognize today. The first patient that I'd like to think about is named Max. He came into our team's awareness in early 2020, right when fentanyl was really starting to take hold in the Portland area. Max was in his late teens, and unfortunately, he had started to struggle with fentanyl use. He reached out quickly, trying to get some help with fentanyl withdrawal, which is really meaningful given the struggles that many patients were having at that time. He got care, he got some support with withdrawal management, and he got a referral to our team. We had an appointment scheduled for him 48 hours after that initial urgent call. Unfortunately, Max did not make it to that appointment. He died from an unintentional opioid overdose within 36 hours from that call. Max's story really highlighted to me the importance of harm reduction strategies and harm reduction education that should spread along the continuum of our health system. And it's Max's story that's really driven the work that we've been doing in Northwest Permanente and nationally with Kaiser Permanente over the last 5 years. I wanted to share a story of hope, and that is one of Lily. Lily's someone who's been working with our team for over 10 years. She's struggled with use of heroin by injection and really couldn't find any medication that was supporting her. She tried naltrexone, she tried sublingual buprenorphine, multiple inpatient stays at our residential center, and really just struggled with continued return to use. Then came along long-acting injectable buprenorphine, thanks to innovation and policy changes in early 2020 as well. I'm happy to say that Lily is now moving into her 6th year of receiving the long-acting injectable buprenorphine. She's been able to see her son graduate from high school and then college, and she's been able to maintain her career in her chosen field. The last patient that I'd like to highlight is someone that I just spoke with on Friday, 3 days ago. And I think he's a sign of where we're going in the future with regards to opioid use and the opioid use epidemic. His name is Johnny. He's in his late 30s, and he managed to stay away from using any fentanyl for the last couple years. He works in manufacturing, is on his feet all day long, and he's really struggled with foot pain. He found Kratom. It's here in Oregon. It's for sale in gas stations, convenience stores, and he started using it. He found that it managed his pain, and then he needed more and was spending more money on it to be able to manage his pain and avoid withdrawal. Then he found that he needed more than that, so he started using alcohol and also cocaine to manage the discomfort he'd feel when he'd come down off of the Kratom. We've been able to support Johnny in helping him get onto sublingual buprenorphine over the last couple of weeks, but he's really struggling in changing his use pattern when it comes to alcohol and cocaine, and that's what led to his call on Friday. So as we move through this conversation with our panel of experts, I'd like to keep Max, Lily, and Johnny, and all the other patients that we care for at the forefront of our thoughts as we're thinking about policy changes for the future. So without further ado, I'm going to start by introducing our panel of experts. To begin, we have Dr. Andrew Kolodny. He is the medical director of the Opioid Policy Research Collaborative at Brandeis University. Dr. Kolodny.
Thank you, Sarah, and it's a pleasure to be here today and to be able to join this discussion. For my opening statement, I really just want to show a few slides and some data that I think will inform the discussion. Next slide. This, of course, is data that I think you're all probably familiar with. We've seen headlines recently about the decline in drug overdose deaths in the United States, and this has really been a decline in opioid overdose deaths. And this is big news. If you were to look at this graph, actually, if you look in the middle of the graph around 2010, that was a point at which the CDC was referring to the opioid crisis as the worst drug addiction epidemic in US history, pointing out that the death toll was far higher than what we had seen during the height of the heroin epidemic of the 1970s and the height of the crack cocaine epidemic of the late 80s, higher than those two epidemics combined. And that was in 2010. But what you can see with this graph is that deaths just continued to mount. And then a couple of years prior to COVID, as you see on this trend, we started to see a soaring increase in drug overdose deaths, driven primarily by fentanyl. And then starting in the fall of 2023, we've seen this decline. And this decline is very big news. If for more than 25 years, if each year we were setting a record and then breaking that record, the decline is something significant. Of course, it's certainly too soon to celebrate. We are still experiencing an enormous number of drug overdose deaths every year, but the decline is something that at least gives us some light at the end of the tunnel. And it's something that many policy researchers are trying to study to understand why the deaths are coming down so significantly. In Renee's introduction to today's discussion, she mentioned much of the hard work that we've all been doing, work to expand access to treatment for opioid use disorder, to prevent opioid use disorder, harm reduction efforts, expanding access to naloxone, and of course, all of that work does help explain the decrease. But if you look at this decrease, and if you look at how steep the decrease is, it suggests that there is something else happening. And in fact, the decrease in deaths has been as steep as the rise that we saw in deaths right before COVID. So there is more happening here, and we should acknowledge that. And I'll show you some data on that in just a sec. Next slide. This is the most current data we have from the CDC on opioid overdose deaths in the United States. If those of you, if you haven't seen the CDC's provisional drug overdose death website, I suggest you take a look. You can find it through Google pretty easily, and you can actually select by state and specific drugs. This is the national picture. It's a couple of months outdated. I think the shutdown slowed down the release of the latest data. By now, we should have had the November data. But what you see, again, is this very significant decline in drug overdose deaths, driven primarily by a decrease in fentanyl deaths. And if you were to look at different states, it's a slightly different picture. But this is the national picture. Next slide. So I mentioned that there's something else going on here. It's not just our good work that explains the decline in deaths. And that other thing that I think is helping explain why we've seen the very significant drop relates to changes in the drug supply. And one of the reasons that we saw the skyrocketing in drug overdose deaths in the United States just prior to COVID and then through COVID was because the drug supply, in particular the black market opioid supply, had become extremely dangerous because of fentanyl. And it does seem like changes in the drug supply may explain why we're seeing the significant drop. This is data that comes from DEA drug seizures. And what we're seeing is that the average amount of fentanyl in the average dose that somebody might use of an opioid on the street, be it either powdered drug or counterfeit pills, the amount of fentanyl has been coming down. And this, if you listen to the DEA explain this, they're suggesting that this is a function of effective efforts to crack down on the precursor chemicals that are used to make fentanyl, which has made it more expensive for the cartels to manufacture to fentanyl products. And actually through interdiction efforts, it's become more difficult for some of the cartels to bring in fentanyl into the United States. What this means is that the wholesale price of fentanyl may have gone up, which translates to the amount of fentanyl in the average dose on the street having come down. And that may be why we're seeing a significant drop in deaths as well as the work that we're all doing. Next slide. This is a slide, again, that you're all familiar with if you've been in any talk about the opioid crisis. I'm showing it here to really critique it in a sense. Obviously, this is showing appropriate data. It's giving us an understanding of the opioids most likely to be found in a decedent's toxicology report, but I think it's actually not that helpful to frame the opioid crisis around the waves of the opioid most likely to be involved in a decedent's toxicology report. I think that the correct way to really think about the opioid crisis is as an epidemic of opioid use disorder. We do know that the vast majority of deaths are occurring in people with a preventable and treatable condition, opioid use disorder. And if we focus too much on overdose deaths as opposed to an epidemic of opioid addiction, we may miss that critical point. The other problem here is that often when we see this graph, there's a narrative that goes along with it that's not really that accurate. You'll sometimes hear this described as, or the explanation for these trends is that drug users are shifting from one drug to another. The implication being that we have this homogenous group of drug users in the United States who are switching from one drug to another based on availability. And we really don't have a homogenous group. There is an epidemiology of opioid use disorder that's critical to understanding the current trends. And the geographic differences, the state-to-state differences are also very important and need to be understood. And then just lastly, sometimes you'll hear with this graph, you'll hear that there was a crackdown on prescription opioids that occurred around when the heroin and fentanyl waves started to go up. And in other words, a crackdown on the pills caused these other waves to happen. And that's not really accurate either. The switching from prescription opioids to the black market happened much earlier than 2011 in most parts of the United States. And when fentanyl emerged, when heroin, those waves emerged, we were actually near the height of prescription opioid consumption in the United States. It wasn't when the pills had dried up, and that's an important point. Next slide. So I mentioned there's an important epidemiology that people have to really understand to make sense of current trends. And if there's anything you're going to get out of my opening statement, I'd like you to sort of understand the epidemiology here. We, roughly speaking, have three groups of opioid-addicted Americans. The first group is a group that switched to the black market after getting addicted to prescription opioids. It's a group that's disproportionately white, disproportionately suburban and rural, and it's a group that's been hit very hard by fentanyl. The second group here is a group that's also disproportionately white. These are middle-aged and older folks that have never really turned to the black market. This is a group that became addicted to prescription opioids. And prior to fentanyl emerging, illicit fentanyl emerging, it was the group number two where we saw most of the deaths. And then the third group is a group that really doesn't get that much attention. It's a group that didn't switch to heroin or fentanyl after getting addicted to prescription opioids. It's a group where their opioid addiction began with heroin use. This is a group that's disproportionately male, disproportionately Black and Latino and urban, and it's an older group. Many of them became addicted to opioids in the 1970s and 80s. Next slide. I want to just finish up here with one other piece of positive news. It's not just deaths that have been coming down, which is sort of a newer phenomenon starting in the fall of 2023. But as prescription opioids began to decline, another benefit that we saw from that was a decline in infants born with opioid dependence, infants with neonatal opioid withdrawal syndrome. And what you're looking at here is data from different states that had experienced a very sharp increase in infants born opioid dependent. A couple of years after prescribing began to come down, we started to see a decrease, and this decrease is continuing across the country. So in hospitals that were treating many infants born opioid dependent, they're seeing far fewer infants that need to be treated for opioid withdrawal at the beginning of life. What this is telling us is that as prescribing trended in a more cautious direction, that fewer women of childbearing age became newly hooked on opioids. It suggests that the incidence, the number of people becoming newly addicted each year, has been coming down. That number is still too high. There are still too many Americans becoming newly addicted to opioids because there is still an overprescribing problem, but there's also a problem with kratom. Many people are becoming newly addicted through use of kratom. But what this really does tell us is that opioid use disorder can be prevented. And really the long-term way to bring the epidemic to an end is through further decreases in the incidence of opioid use disorder. I will stop here. Thank you.
Thank you very much, Dr. Kolodny. Now moving on to our next panelist, I have Ms. Sara Whaley, who's the Executive Director of Overdose Response at the City of Baltimore.
Thanks, Dr. Leitz. So I'm Sara Whaley, and as Dr. Leitz mentioned, I am the Executive Director of the Mayor's Office of Overdose Response here in Baltimore City, but previously was faculty at the Johns Hopkins Bloomberg School of Public Health, where I got to lead our technical assistance work around opioid settlements. So I get to wear two hats today, talking about opioid settlements and how Baltimore City is using our opioid litigation dollars. Next slide. So when we talk about the opioid settlements, we often talk about them as just like one thing, the opioid settlements. But to give a little bit of context and background, I want to share kind of how they came about. So what we have is actually a collection of a lot of lawsuits where the plaintiffs that are shown here in purple sued the defendants here in yellow for their role in perpetuating the overdose crisis. And just to give a little bit of quick math in the afternoon, we've got 50 states. There were over 2,000 participating counties, 7,000 plus cities, some other municipalities. There were also 574 federally recognized tribes that sued these companies, and then numerous school districts as well. So when we combine all of those together, there's over 10,000 separate lawsuits against each one of these entities. Next slide. So obviously, when there are that many cases, it gets a little complex. And so to give not only the courts a break, but probably the attorneys as well, many of these cases were brought together in what's called multi-district litigation, which is a legal process where the courts consolidate related cases from multiple districts into a single court for pretrial proceedings. And this process aims to, again, streamline the litigation and reduce any burdens on the court systems. So as the companies began to settle with these states, there were added incentives for the states if the majority of their jurisdictions or other the counties and cities and municipalities that sued, if they signed on to the settlement agreements. Next slide. So what resulted from these negotiations is over $50 billion to cities, states, and counties that will be paid out over time. And while this sounds like a lot of money, and it is, I do want to note that as it's distributed down to the cities, states, and counties, and over the period of time, it pales in comparison, I think, to the profits that were made by these companies. And Purdue Pharma alone made over $34 billion in revenue off OxyContin between 1995 and 2014. So there's a quote here from William Tong, who was one of the AGs that helped negotiate these settlements, and just putting into context how the the profits of these litigation compared to the costs to communities and families and individuals. Next slide. A little bit about the default settlement terms. This is just a high level, but for the majority of these cases, funds will go to the state, 85%, and then 15% to the local participating jurisdictions. However, many jurisdictions have changed this default allocation. I'll use North Carolina as an example. They've actually flipped the 85-15. So 85% is going to the local jurisdictions and 15 is going to the state. The second pie chart shows the uses. So the majority of the funds, 85%, have to be used on future opioid abatement expenses, which is great. So that, we're looking to the future. And then how the dollars have to be spent. There's a list of approved uses and core strategies listed in many of the settlement agreements. And I'll just note that many states have also introduced legislation or MOUs or MOAs, memorandum of agreements or understanding for their jurisdictions that might change some of these default allocations. Next slide. So when we look at how states could set up processes to be most successful for their opioid settlement funds, we have some other public health lawsuits that we can look at as examples. The tobacco master settlements in the 1990s resulted in over $200 billion paid out to participating states. But despite the terms of the tobacco master settlements, many of the funds did not go to tobacco prevention, cessation, and healthcare costs associated with smoking. Tracking done by the Campaign for Tobacco-Free Kids actually shows that less than 3% of the tobacco settlement funds went to those things. And so we kind of look at this as an example of what could have been done differently, especially with, the toll of the opioid crisis in our communities. We wanted to make sure that these dollars are going towards opioid-related programming. And so there's some key lessons learned from this settlement, keeping the dollars separate from the general fund, which improves tracking and makes sure that they don't get lost and aren't used to fill budget holes or for capital projects or things not related to opioids or to tobacco in this case. The second takeaway here is having a clear process for decision making. So when the funds are separate, who's in charge of them and who's making the decisions. And then for accountability and public transparency, just having information be made public and easily accessible helps ensure accountability that the dollars are going towards programs related to the overdose crisis. Next slide. So with that aim, the team at the Bloomberg Overdose Prevention Initiative at Johns Hopkins School of Public Health put together a set of guiding principles that have been endorsed by many different stakeholders across the country. Next slide. The principles are listed here. And these principles, again, have been endorsed by many different organizations and adopted by jurisdictions across the country. Next slide. As part of this project around the principles for, the last, 5 years or so, the question that we get asked a lot was around how the funds are being used. And so KFF Health News, faculty from Johns Hopkins, and then folks from Shatterproof, a national nonprofit, came together to try to answer that question. And they took on a national data tracking project to answer that question of where the settlement funds are going. And so this project has been completed twice now. They've looked at data from 2022 to 2023 expenditures, and then most recently published expenditures from 2023 to 2024. And this data was collected from looking at publicly available websites or dashboards from attorneys general offices, health departments, any nationwide opioid settlement councils, and then also from the National Settlement Administrator. Next slide. For the first iteration of this data collection project, looking at nearly $6 billion that had been received and paid out to states, about a third of those funds were committed to projects. Another third was uncommitted, so sitting in the state's bank account, but not yet committed to any project. And then another third of those funds were untrackable. So there was no publicly available data on if they were spent and on what. Next slide. And while reporting is getting better, we've seen progress from the first time this project was completed until the one that was just published, but there are still 16 states where at least 30% or more of their funds are still not publicly available. So I think when we ask the question around how dollars are being spent, the first step to get us to answering that question is having that information be made public. And we're not quite there yet. Next slide. But for the money that we do know where it went, we can see here in this pie chart that for data from 2022 to 2023, lots of money went out. Over $400 million went to the treatment bucket, which is this, I guess there's two greens, the like darker green color. $360 million went to harm reduction, which is shown here in the light purple. And then over 300 million again to like recovery support services. So lots of money going out to different buckets of spending. Next slide. This is a very busy graphic, but this is spending from the 2023 to 2024 report that just came out, and we're seeing lots of different types of expenditures, but on the right side, you can see the different buckets and how the money is flowing into those. Again, you see large amounts of funds going to treatment, harm reduction, and recovery, but over 10,000 different ways that states and local governments are spending their opioid settlement dollars, which is lots of variety. And so I think a takeaway from this is that there is no one-size-fits-all approach to how to spend this money. Every jurisdiction has different needs based on the scale of the crisis and the scope of their existing resources that have been funded from other different funding sources over time. Next slide. And with that, I just want to give a little bit of background on Baltimore because we are in a unique situation. So Baltimore City was a non-participant in the global settlement. So we participated in some of the global settlements with Maryland and with the other states, but eventually opted out of participating in other cases and decided to continue independently. Through settlements or jury awards, we have received just under $580 million. And in our bank account so far, we have received just over 200 million of those dollars. Most of ours will be coming in as lump sums rather than paid out over the 18 years. And we just started to get our dollars. So while states and the other states that participated have had a couple years, ours is fairly new. But to help with that and to get money out through our negotiations and settlement, there were some earmarks. So 22 programs or organizations were named in our settlements to receive earmarks that total $87 million. We'll be entering into grant agreements with all of these programs. It's obviously a non-competitive grant process since they were named to receive that money, but we'll still be requiring them to go through a grant application process to tell us how they will use those dollars. And they'll be required to have oversight and monitoring so that we can report out how those funds are being spent. Next slide. And I really want to stress that our approach in Baltimore has really been focused on the needs and the infrastructure in the city already, and trying to use the opioid settlement dollars to fill gaps within our existing system. So we are required by the mayor's executive order that outlined how we would spend our restitution funds to complete a citywide needs assessment that would inform a strategic plan. And so we are going to do this every 2 years, and all of our investments will be tied back to the data that we're seeing in the city. And as Dr. Kolodny mentioned, we're not looking at just the fatality data. We also want to understand the full picture of the epidemic in the city. So we're looking at non-fatal overdoses, who and where they're happening, what drugs are in our drug supply. And then we're also collecting qualitative data on the experiences of people who use drugs in the city, how they're navigating the different programs, and talking to providers about what their needs might be as well. And so based on what we've been able to see from this first iteration of needs assessment and strategic planning, we currently have a request for proposals out right now in the city for mobile treatment services, mobile harm reduction services. Since we saw geographic disparities throughout the city, these areas that have high need but lack brick and mortar programs, we thought utilizing mobile services might be a good idea to get programs into those geographic areas where there's disparities. And then we also have a smaller grant for social support services like transportation and food, since we heard that there's other grants that folks are using that don't cover those types of social supports that are needed for Baltimore City residents. So I will end there and want to say thanks and looking forward to the questions.
Thank you very much, Sarah. That was very helpful and informative. Our next panelist is Miss Alisha Nelson. She is the Executive Director of OneOhio Recovery Foundation.
Well, hello, and thank you all for having me. Hope you all are well and receiving all this great information. I am going to tell you a little bit about what Ohio has done as it relates to our opiate settlement funds. And it really connects to what our first two panelists have already talked about. So I will try to make those connecting points. But back in 2007, Ohio was one of the first states to sue the opiate manufacturers and distributors. We knew at that time that we had a good case, and really at that time also started to think about what would happen if we were to continue that work, and what would we do with the settlement proceeds. So I'm going to talk a little bit about what has evolved since 2017 and where we are today. So if you go to the next slide there, what we did, as Sarah mentioned, or one of the states, every state has a little bit different flavor to our distribution formula. We took a look at, again, the tobacco settlements, and we knew that we wanted to think about these funds a little differently and really think about the long-term trajectory that these funds could have in finding solutions for our state. And so to do that, and our best way to kind of protect the funds from other uses was to put 55% of the dollars, every dollar that comes to the state of Ohio, in the OneOhio Recovery Foundation. 30% goes directly to local governments, and then 15% goes directly to the state. So I do not have oversight over that 30% or the 15%, but information about all of the settlements and their uses are available on each of their respective websites. All right, so if we go to the next slide. So what did we do here in Ohio? To protect the funds further than we really had that experience with the tobacco settlements than we've done in the past is we decided to establish a nonprofit charitable foundation. And so we really are linked directly into the settlement agreements themselves, and funds do not flow through our legislature to OneOhio, but straight from the National Opiate Administrator to us as a part of this process. So that really protects the fund and makes sure that it is used for the intended purposes for many years to come. So if we go to the next slide, but we also didn't want to lose that, important work of community input. And so with our settlement agreement, it created what we call our OneOhio region. So every county in Ohio, counties that sued and counties that didn't sue, I think we had 68 counties that sued at the time, are a part of our OneOhio regions. And so with those regions, we have community boards at every region who are individuals with lived experience, individuals in the clinical community, our universities and schools, alongside commissioners, mayors, and the like, who sit across the table from each other each year, and we talk about how funds could best serve the region that they serve. So if we go to the next slide, we just did our first grant round. And so our first grant round, first cycle for us, concluded in 2024. We're gearing up for our next grant cycle for anyone from Ohio that is on the line. But our first grant cycle taught us a lot, how to do collaboration in the way that we're talking about. That map shows 19 regions, but that's really over 375 people across the state who help us make informed decisions and recommend the grants that they think will best serve their community needs. And so through that grant cycle, what you see here is that $45 million was awarded to 245 projects representing 202 organizations. What I love most, and what I'll talk about here some more in a second, is that these dollars primarily went to, as you can see on the screen, prevention services and recovery supports, which we know are services that are typically, at least in Ohio, have been lacking funding from other sources. So if we go to the last slide here, I just wanted to talk a little bit about some of our key insights that we have found since we began our journey as the OneOhio crew here in Ohio. And it was really about supporting the first point, a full continuum of care. And I think Dr. Kolodny spoke to this some earlier, really, getting away from this concept of, really picking out one particular problem, perhaps opioid programming or methamphetamine programming, and really focusing more holistically on substance use disorder treatment. And I think that that's been a game changer for funders in Ohio, because I think treatment providers felt really limited in what they could do when they had someone present in their office or their clinic, et cetera, and they had only dollars that could really focus on opiate use disorder. And so hard to believe that's where we were, but we've made a lot of progress here in Ohio to move away from those types of funding opportunities and really looked at that full continuum of care. I think the other spot that I'll just say that I'll quickly say that was on there is just thinking about priorities that lift all boats, but I'd be happy to talk more about those things in our question and answer. I see the last slide is up. Thank you.
Thank you very much, Alisha. Those were three very useful introductions to move us into our panel questions. I'm going to ask this first question is aimed at both Alisha and Sara with a state opportunity. And I'm going to ask for responses to remain short, as we do have a number of questions that we're hoping to get to. So with that being said, states are using their settlement dollars in many ways, as you both have just described. Are there interventions tied to outcomes that are most promising? What can states do to prepare for the next wave, likely needing to better manage care for polysubstance use? And Sara, I'll ask you to go first.
Sure. So I think really when we think about tied to outcomes, we want to look at the evidence-based solutions. So programs that we know work and work well, and thinking about innovations and how we address polysubstance use and a more chaotic drug supply. I think we would be remiss if we didn't mention the innovative work that's happening in Rhode Island and how they have used their opioid settlement funds to fund the partnership between Project Weber and Renew for the Overdose Prevention Center there. So really thinking about how we go beyond, what we're doing now and think about comprehensive harm reduction and safe spaces for folks. I know that's something that we are really aware of here in Baltimore because we've had 3 mass overdoses since July of this year. One from a novel benzodiazepine that was mixed into the drug supply and from medetomidine. And so we are thinking about how we use comprehensive harm reduction strategies. So not just naloxone because the drug supply is changing, but drug checking services, low barrier drop-in, and things like that. So, yeah.
Thank you. That's very interesting. And Alisha, what would you like to say about state opportunities?
Just to be quick, I think, for us, it's a little too soon to say how our investments are working, but I can talk about what we're excited to see. And those are things like hospitals really engaging in a way that I haven't seen in the past here in Ohio, really looking at low barriers to medication-assisted treatment, MOUD treatment, and things of that nature. We're really seeing an insurgence of peers, but thoughtful use of peers that I'm excited about, and really this overall overarching blend of the academics who understand evaluative measures with community folks who are super passionate, who are willing to kind of sit across the table to understand how to evaluate this work effectively. And so I'm excited to see those conversations happening.
Thank you very much. And now looking to current state and trends, and this one's for you, Dr. Kolodny. As you shared, overdose deaths dropped in 2024, the largest single decrease since the start of the opioid epidemic. We know there is no singular reason for this decline, as you already outlined, but what can we learn from this change to inform future interventions?
That's a great question. I think one of the lessons that we can learn is that supply and demand are interrelated. I think that there is a tendency for many of us who work in public health or treatment or prevention to really think about drug addiction epidemics or drug problems as really a demand problem. And we tend to have sort of this negative perception of supply interventions. And of course, the war on drugs rightly has a bad reputation because it led to mass incarceration and isn't, arresting people is not the answer to addiction epidemics. But I think that one of the lessons here is that supply interventions are important. It really does seem that efforts to crack down on precursor chemicals that were used to make fentanyl and efforts to reduce interdiction efforts have made the price of fentanyl on the street higher. We have a long history in drug policy that tells us that when purity goes up and price goes down, more people who are addicted die. So that's one piece of this, is that there really is a role for supply control interventions. But, if you think back about the opioid crisis in general, how did we wind up with an epidemic of opioid use disorder in the United States? Well, it was the result of a massive oversupply of prescription opioids. It led many people to become opioid addicted. It led to demand for heroin and fentanyl. So again, I think one lesson here is that it's not about just, are you on the demand side or, demand prevention side or supply reduction side. I think it's about, really that they're all interrelated, and that if we're going to reduce or address addiction epidemics, we have to think about both prevention, demand reduction, and supply control.
Thank you. That's very helpful. This last question, before we start taking questions from our audience, is for each of you. It's around policy solutions. We've heard about promising research and state solutions today. Are there any other policy solutions you'd like to highlight today, either at the state or federal level? Dr. Kolodny, I think I will turn to you first.
So in terms of solutions that I would like to highlight, and maybe this is an opportunity here for me to sort of give my pitch for something I would like to see states and counties doing across the country, particularly with their settlement dollars. What I'd like to see is our low threshold treatment programs. And when I say low threshold, typically what that might mean for many people would be a harm reduction organization with a van, meeting people where they are, making buprenorphine available to people with opioid use disorder, a doc prescribing buprenorphine or giving it to someone in a parking lot somewhere. And those are very valuable interventions that save lives, that engage people in treatment. But for a life-threatening condition like opioid use disorder, I think we should be able to do better than meeting a patient in a parking lot. During the AIDS crisis, we weren't meeting patients on street corners to give them antiretroviral therapy. We had the creation of a Ryan White funding stream. We had as a nation a decision that if people were HIV positive, they should have access to antiretroviral therapy, regardless of their ability to pay for it. And people have access to these Ryan White treatment clinics that offer an array of services to help people who are HIV positive. That's what I'd like to see for people with opioid use disorder. We don't have the federal funding stream, but we do have the opioid litigation dollars. I'd like to see a program where somebody could walk in that same day and get access to effective treatment for opioid use disorder, regardless of their ability to pay for it, where there's no financial clearance, no barriers or hurdles for people to jump through, no telling somebody come back next week when the doctor's here who can do the induction, and where you offer co-located mental health and primary care services for these folks. And so really state-of-the-art treatment that's very easy and essentially free. If we could get there, I really do think we'd see deaths come down more substantially if treatment was as easy to access as fentanyl.
Thank you very much. Sara, I will turn to you next.
Sure. So similarly to Dr. Kolodny, I think just general access to healthcare, thinking about how the Affordable Care Act increased access to life-saving treatment for so many people, the changes to insurance make me really nervous. And so policy-wise, I think my call to the federal government is to make sure that we continue to have general access to healthcare. It would be really devastating for people who use drugs to lose healthcare access, not just because of their treatment, but because of all of the comorbidities that go along with it. And just thinking about whole person care and access to healthcare is so necessary. I've also already talked about OPCs. I'm a big fan, and so would love to see that, but also want to push our policymakers to think about safe supply as well. As I mentioned, drug supply here in Baltimore, and I know across the country, is changing and becoming more chaotic. And folks think that they're using something that they're used to, or they know what they're getting, and they don't. And so I think thinking about how we, as Dr. Kolodny mentioned, change the supply. And I think one avenue for that is making it safe.
Thank you very much, Sara. And last but certainly not least, Alisha Nelson, what are your thoughts on policy solutions?
I agree with what has been shared. And I think for me, one of the things that I've been kind of leaning in more and more on is this notion of collaborative efforts and how we can support payment systems and structures that can incentivize those collaborative efforts, whether it's a quick response team or integrated health models that, bring the folks together to meet people where they are. It's been a challenge, and many of them are relying on settlement dollars to support those collaborative efforts. And, that's not a sustainable strategy given, as we said, these dollars are limited, time limited, and also fleeting. And in a state as big as Ohio, they go fast. And so we really are looking at ways to incentivize that collaboration across different systems, criminal justice, healthcare, et cetera.
Thank you. We're going to turn to questions from the audience at this point. So the first question we have is around kratom. I'm so glad to hear you elevate the issue of kratom. I have a family member who used it to curb cravings for alcohol. He ended up being addicted to kratom, and the withdrawal was terrifying. People later shared with him that it was similar to opioid withdrawal or worse. It is easily accessible at corner stores in most places. This, combined with it being marketed as a supplement, are contributing to a perception that it is a safe drug when it clearly is not. I worry that people will not seek treatment for what they perceive as an all-natural product. What can we do from a policy or clinical perspective to elevate the risk of kratom? I'll leave it to the panel. It looks like Dr. Kolodny has a response.
Sure. I think, what we should do about this is very clear. It should become a Schedule I drug in every state in the country, or it should be nationally a Schedule I drug, and then states wouldn't have to schedule it. A Schedule I drug is a drug that would be banned, a drug that's highly addictive, that has no medical use. And there is no proven medical uses for kratom. You have an industry that's pushing messages that it's good for pain, it's good for anxiety, it's good for opioid withdrawal, and that it's a natural product. When it is an opioid, you sometimes hear it described as an opioid-like drug. It's not an opioid-like drug. It is an opioid. The definition of an opioid is a drug that really activates the mu-opioid receptors, and that is what kratom does. You have an industry now that's trying to sort of push a message: kratom is good, 7-hydroxymetragenine, or gas station heroin bad, and certainly 7-hydroxymetragenine is more potent and potentially more dangerous than kratom, but kratom is not safe. Both should be banned in every state in the country. So the policy, what needs to be done on a policy level, is very clear. Achieving it is very difficult because you have a powerful industry that's earning literally billions off of this product right now, that's invested in maintaining the status quo. And if anything, we're seeing states that had previously banned it overturning the ban on it. For example, Rhode Island essentially legalized kratom products just recently because of effective lobbying from the industry. I do worry because I do think that I know that kratom use is increasing the incidence of opioid use disorder in the United States. It's the opioid that people are becoming newly addicted on or relapsing to it, as we heard in the description of Johnny in the opening. And so I really do think it's necessary to take action on this quickly.
Thank you very much, Dr. Kolodny. Alisha or Sara, did you have anything to add? No.
I don't have anything to add on the policy front. I think Dr. Kolodny was spot on, but I do think that state and local health departments can help with the education around kratom and really using their voice and the resources around public education campaigns to let folks know and help direct them to assistance. As the question said, folks might be afraid. And so just making sure that people know what their options are. And that's the role that I think at a local level we can help to play.
I think that is so important too, because so many people aren't even aware that it's harmful or that there's options for treatment too. We have another audience question. How can we get more buy-in from schools, both public and private, universities, civic organizations, and parent-teacher associations to support on-site education, training, and distribution of Narcan. Alisha, what are your thoughts there?
Thinking on that. I think, awareness is always, a hurdle to tackle, as well as stigma. And for us here in Ohio, we've been very fortunate that naloxone is readily available. We have vending machines. We have, websites that if you reach out, you can access them. And we even have a bill. I was trying to remember where the bill is in the process to allow schools to, offer this service. I think, for us, it's been an ongoing conversation. Unfortunately, as some of the national research has shown, 1 in 4 kiddos have a parent with a substance use disorder, likely here in Ohio. And so I think it's been an awareness building tool to have some of that research come out. And we've had less and less barriers to connections with schools. And it's really finding ways to make it easy for schools to implement when they already have so much on their plate.
There's a lot being asked of schools these days, that's for sure. Sara, Dr. Kolodny, did you have anything to add there?
No, I thought that was good.
Okay, we've got one last wrap-up question. And I'll ask each of you to respond to this one. What is the one thing that you hope our audience will take away from today's conversation? And Sara, I'll have you go first.
That's a big question. But I think my hope for the audience to take away from this is that, when we think about opioid settlements, if we think about the future of this crisis, really looking at not opioid settlement funds are not a magic bullet, but they're really an opportunity for intentional spending and coordinated advocacy. And Alisha made a really good comment about the coordination across services and how collaboration is so important. No one has enough money, even with the opioid settlement funds, to do all of the things I think that we would like to do or that we need to do. And so bringing all of the partners together and thinking about how to use the dollars in a nimble way to fill gaps in services, I think is what we need to do, and thinking about long-term solutions and how we use the settlement funds to build up our capacity to think holistically and long-term about what this crisis looks like, because we've mentioned all of these other substances, and if the opioid crisis is over, there will be something else. And so if we think broadly about how to support our residents, to support individuals that use drugs, I think we'll set up better systems that can meet the needs in a more effective way.
Thank you. I'll turn to Alisha next.
I think I'll just keep piggybacking off of Sara. I think for me, I hope folks take away that collaborative, spirit. Everyone has something to offer here, whether it's an individual with lived experience, a family member, clinician, licensed, trained, or, a local mayor, township trustee who's receiving the settlement dollars. I think, really bringing everybody together to have conversations about the mutual benefit that we can have with our diverse thoughts and knowledge is really going to be the trick to kind of lift all boats and appreciate that this is a complex issue. It's far-reaching, and it's impacting, I would say everybody. And so we really have to think about solutions, not just from our one lens, but the collective lens, and really support the others' ideas as well.
Thank you. And Dr. Kolodny, what would you like people to take away?
So I agree very much with those final points. What I would add really is just coming back to something I had said in the opening with regard to the opioid crisis. When we think about the opioid crisis, I would just urge folks to try and understand it as an epidemic of opioid use disorder or opioid addiction. And if you frame it that way, the primary interventions are clear. We have to do everything we can to prevent more people from becoming opioid addicted. And there are different interventions there I won't get into right now. And we have to do everything we can to make sure that people who have opioid addiction have very easy access to effective treatment. And if we can achieve both prevention and better access to the most effective treatments, and of course there's a role for harm reduction and supply and prevention, if we can do that, we really can tackle this problem.
Well, thank you all. That brings an end to our questions. And I just wanted to, before I turn it back to Renee, share huge appreciation for this conversation and for really the key points that each of you made. It's very helpful, and I really appreciate it. Back to you, Renee.
Thank you, Dr. Leitz. So first, I would like to echo your comments. Great thanks to our esteemed panel for sharing their perspectives on the opportunities and challenges we face in tackling a very complex issue. Today, we did cover a lot of ground. We began the conversation by hearing about several patient stories. We looked at, how we got here and what else is happening to impact deaths, namely changes in the drug supply. We covered a little bit about what led to the state settlement funds, along with lessons learned from the tobacco master settlement. And our speakers spoke today about the importance of same-day access without barriers, including the ability to pay for treatment that is co-located within mental health and primary care services. One quote that I will carry with me is from Dr. Kolodny: "If treatment was as easy to access as fentanyl." We also heard about the importance of general access to healthcare being so essential for substance use disorder treatment, and a threat to coverage is also a threat to treatment. And lastly, the importance of collaborative efforts and how to support payment structures that incentivize collaborative care models. So with that, thanking our audience for joining us today and all of our panelists, I want to close out and also thank the Institute for Health Policy staff, including Kristen Joyce and Ben Thrutchley. We'd also like to thank our broader team of subject matter experts within Kaiser Permanente that advised us on today's events. And lastly, we'd like to thank our partners at Spark Street Digital for their ongoing support of our events. We will again be, just a reminder, posting a recording of this event on our website in the coming weeks. And the QR code for our post-event survey is on the screen now, but we'll also be following up and sending that to you in a follow-up email. Thank you for joining us today.